we are concerned about the heart, but what about the lung? So, lung can also have some common problems which is associated with which are seen in day-to-day life as well. So, I have tried to include them as well. So, if you will remember, I was talking about the radio opacity, the whitishness, or the radiolucency. Radio opacity, where you see the pleural effusion can be there, consolidation, collapse, fibrosis, medullary lesions, or the lymphadenopathy, or even the pulmonary edema can be seen. The radiolucency is, so for example, the lung fields will appear pretty black. So it can happen in conditions like the pneumothorax, hydropneumothorax, emphysema, or even the subcutaneous emphysema as well. So let's first of all try to have a look on the pleural effusion. I already showed you some of those examples. So what do you notice over here? Anyone would like to describe? Try.
The costophrenic angle is gone.
Gone. Gone where?
Uh, we cannot see the costophrenic
Okay,
angle.
good, good, good. So this is how will you describe the X-ray? I taught so many shortcuts as well. Okay, good. That's a good thinking, in fact. So I really appreciate it. So what happens is the other thing is how do you can you comment also about the amount of pleural effusion? Is it how much ml is it? Is it mild or minimal pleural effusion, moderate or very severe? So even with the X-ray, if if you are able to determine the pleural effusion only in chest X-ray lateral decubitus, it is going to be 10 to 50 ml. Okay. However, if in chest X-ray PA view, if you are able to determine, it is going to be almost 150 to 175 ml. Otherwise, with the ultrasound in the thorax region, even if it is as little as 3 to 5 ml, you will be able to determine it, in fact. So now coming, yeah, so that's what I was talking about. So what about the consolidation? So about the consolidation, what happens is, you can see over here, right? And then comes is the collapse. So what do you notice in collapse? Anyone would like to try?
Shifting of trachea,
Good, good, good. And
lung opacities,
so what happens is atelectasis or collapse or even incomplete expansion is one of the most common uh, finding which tends to happen. So what happens is, as you may notice, so there is opacification over here. As our friend also rightly pointed it out, in fact, over here, um, uh, there can be various etiologies for that. If there is a mucus plugging is there, or there is aspirated foreign material, in fact, as well. So, for example, a child comes who says that the mother complains that, oh, the boy sniffed in some dust or some some solid stuff as well, like this. Okay, so that is what you may be able to notice over here, and of course it tends to correspond to the different lung fields as well. Wonderful. So you all are now the expert masters in this as well. So these are the different examples if you will see. So this is for the right upper lobe. Hmm?
collapse,
Yes, exactly, and or atelectasis as well. So over here in this, like almost the middle and the lower right side is all gone. So you can literally pinpoint as well. So that's why it's really important to have a look. So what about fibrosis? What are the changes you notice in fibrosis of lung?
lifting of trachea on the same side.
Okay. Interesting. And
Uh, Opposite sides lung opacities are there.
uh,
White lung will be there.
see, only it's very. I really appreciate it, but why others are not telling? We have a lot of people as well, other students, online. I can already see the list. It's pretty huge. Good number of students are there online, but no one is telling. So let's try to see, for example, what are the possible etiologies where it can happen. So the possible etiologies is if there is respiratory failure, pulmonary hypertension, or even the heart failure as well,
Yes,
right?
sir.
Right. So then what happens is, then what do you notice? So what do you notice over here is someone has already said about all these things. So what do we notice?
Cardiac shadow is also dilated, sir. Cardiac chamber,
Good, good. And
which is and there is a fusion in the left costophrenic angle. There is mild effusion is also there.
wonderful,
Yeah,
wonderful.
the terminal bronchioles are fibrous.
So for example, for pulmonary fibrosis, what are the other tests would you like to do?
So VQ scan,
Wonderful. HRCT.
HRCT is fine.
Yes, HRCT is going to be really something. And what are the clinical things you will be able to notice? If you're there with a stet, what can you
also
notice?
will be raised JVP sign, raised JVP.
It depends upon the etiology. So what will happen is with your there with a stet. So if you'll put your stet on those regions, maybe sometimes you may be able to, yeah, hear fine inspiratory crackles at the lung bases. You may be able to hear, right? Hmm.
Yes.
So we were talking about, we all are concerned about the money, but in chest X-rays as well, we also talk about coins as well. So what is coin lesion? Coin lesions, they are, for example, up to 40% of the times they are malignant. So if you see such patients, rule out malignancy. So this is one of the important things, especially for all the doctors, I would really like to say. So what happens is the differential diagnosis for this is going to be bronchial carcinoma, adenoma, the lung abscesses, the pseudotumor, the heightened cyst, in fact, the rheumatoid nodule, or also the Wegener's nodule as well. So this is something really, really important. So we all should keep always in our mind as well whenever we are thinking about it. So now comes is one of the miliary lesions. I think everyone can already say about it. So what are miliary lesions actually? Why is it called? Why is it called as a miliary lesion?
Small multiple opacity will be seen in whole distributed irregularly in the lungs.
Wonderful, wonderful, wonderful. So this is what is happening is due to the tiny size of those lesions, which is around 1 to typically 5 millimeters. Okay, and this is one of the like up to 20% of those extrapulmonary tuberculosis cases as well. One may be able to see. So there is also differential diagnosis as well in sarcoidosis or pulmonary eosinophilia, histoplasmosis, or pneumoconiosis as well. One may be able to see. So, as I was telling you, so for example, over here the miliary nodules are less than 2 millimeters. As I was telling you, pulmonary nodules can also be of different sizes as well, up to ranging from 7 to 30 millimeter, and sometimes pulmonary masses as well. If there is a massive pulmonary tuberculosis, you may be able to see those pulmonary masses as well. So if you look carefully over here, this is a typical X-ray of a pulmonary tuberculosis patient. You must never, 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 never miss it, even in your dreams, I would say. Yeah, the masses are there, huge, mega masses. And over here, miliary small nodules, and there are also pulmonary nodules as well, in fact. So some of those, so these are the signs of pulmonary metastasis. So if you again you see something like this, miliary nodules, pulmonary nodules, or pulmonary masses, alert, a red alert, it should be there in your, uh, and you should alert not only yourself but also to the patient as well. Then comes the lung masses, which you may be able to notice it over here. Then the HeLa lymphadenopathy. So HeLa lymphadenopathy is another characteristic thing which you may be able to see either only on one side, unilateral one, or the bilateral side. So unilateral is more of in tuberculosis, lymphomas, or histoplasmosis. However, the bilateral side, of course, also in tuberculosis as well, sarcoidosis, lymphomas, or pneumoconiosis, especially like silicosis. So the silicosis is more like a occupational lung disease, so seen in the lungs of these people who are working in the silica industry, in fact, and due to inhalation of the silica dust granules in their lungs, this is going to be there, in fact. So that's why one needs to be slightly bit more careful. And pulmonary edema, you all are now the master, I would say. You all will not be able to forget, right? I've already shown you some examples now. Um, Over here, one of the important things which I really wanted to highlight was about the cardiogenic pulmonary edema or the non-cardiogenic pulmonary edema, ARDS, that is what is called as. So it is very important to diagnose that. And why am I talking about this is because a lot of times, especially if a patient is there in the ICU, so you will have to differentiate between those two, because when you want to do the prognostication of the patient, or even if you want to initiate the treatment or the therapy for the patient as well, you should be able to differentiate it. So for example, if it is a cardiogenic pulmonary edema, so of course the heart size is going to be enlarged. However, in the ARDS, acute respiratory distress syndrome, so in which the main etiology is lying in the lungs, so here the heart size is going to be normal. Similarly, about the vascular distribution, if you are going to look, it is going to be either balanced or in fact inverted as well. In the ARDS, the vascular distribution is almost normal or balanced, in fact. Similarly, the edema, if you try to talk, in the heart, the cardiogenic cause, it is more even or central, in fact, the edema is going to be. However, in the respiratory cause, the edema is going to be much more widespread. So, for example, you are able to at least see some clear lung zones and all. Over here, not at all. You can't see anything at all, in fact. So, as I was telling you, pleural effusions, yes, quite a lot. It's pretty common. And the LV failure. However, in the ARDS, mostly it is not usually present. And the septal lines or even the peribronchial cuffing is pretty much common in the cardiogenic pulmonary edema, in fact. Okay, and the ear bronchograms is most commonly seen in the ARDS. So now you are able to understand not just uh, the to be able to differentiate the ARDS, but also from the different causes, right? So, for example, if it has been caused by the lung problem or is it caused by something else? Hmm. So, what about hemithorax? So, what is happening over here? Can anyone recall? Okay, let's try to make it easier for you. So what is happening over here? So this is the condition. What is happening is hemothorax. And why is it called as hemothorax? Because
Single lung is pathological.
right, right. So what is happening is you can see only the half of the thorax. So that is why it is called as hemothorax. So there are three different things which you can see. So the mediastinum can be pushed away from the opacification. So this is the opacification, right? This is the opacification. So the once it can be mediastinum is pushed away from the opacification. Second can be is towards the opacification. For example, in this, if you'll notice, and this as well towards the opacification. Otherwise, the third thing is going to be is it will remain in the middle. Okay, so these are different types of opacification. So in this is remaining in the middle, and this is getting pushed towards the opacification, right? And in this, it is away, right? So these are the three types. So what are those three types? So it is going to be pushed away from the opacification. For example, this is the first type. So this could be is a pleural effusion if there is a large lung mass. Otherwise, if there is a diaphragmatic hernia as well. So that is where it is going to be pushed away. However, it is going to be pushed towards the opacify, towards the opacify sides. So, for example, if you look over here in the last X-ray, if there is a lung collapse, there is a pneumonectomy, otherwise also pulmonary hypoplasia, or there is a pulmonary agenesis as well. So then you will be able to see this towards the opacified side. And the last one, as I was telling you, so it remains in the middle. In terms of consolidation, if there is a pleural chest wall mass, otherwise also there can be some combination of pathologies as well. So these were some of those beautiful examples. Oh, hmm. So what is this one? So already I have given the diagnosis. Pneumothorax.
Me,
Why?
mediastinum is
Why is it pneumothorax? Now the question comes is why is it pneumothorax?
Air in the thoracic cavity, sir.
Great, great. And what else?
And
So what happens is you should try to look for the outer
margin.
margin, exactly, the outer margin of the visceral pleura or and lung. So what is the pleural line? If you are able to see the pleural line, run, 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 emergency. You should try to immediately start arranging the things with which you are going to intervene. So a lot of times a procedure has been done, ablation procedure is done, otherwise um, Uh, yeah, exactly. Yes, yes. So cath procedure has been done, and then patient complains, shortness of breath and all. Then you get this X-ray. So this is the time for action. So this is how you differentiate. As I was telling you, if you're able to demonstrate the outer margin of the visceral pleura and lung, the pleural line, from the parietal pleura. Parietal pleura and visceral pleura is different. So if you are able to see this line, then this is what is the classical pneumothorax. Okay, now hydropneumothorax. Come on, try to understand the English. Hydropneumothorax.
any chylous fluid or any kind of fluid in a pleural cavity.
Okay, good, good. But how do you
Fluid
see?
and air.
Exactly. So you are able to see not just air, but also fluid as well. So do you notice the straight line here and the straight line over here? and you should ideally do in a upright chest X-ray. So you are able to see it's a huge, not just air is there, but also fluid as well. So this is hydro. Pneumothorax, you all are already the masters now. Pneumothorax, you know, hydro is also there now. Okay? Hmm. So the pulmonary cavity. What else do you see? So this is what I call it as a cavity. Cavity is standing for carcinoma, autoimmune disease like the Wegener's granulomatosis or the rheumatoid nodules, the vascular like the emboli, septic or bland, or otherwise infection or abscess. For the bacterial like Klebsiella, Staphylococcus, and Uberic infections, T for trauma, or even in some of those young patients of congenital heart disease or bronchogenic cysts as well, pulmonary cavity. So what do you see over here? Oops, okay, I already gave you the answer and then I'm showing you the x-ray. Ah, bad, 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 bad. Okay, but try to learn these things. So that's why it is important. So these are the pulmonary cavities which you notice. And the diagnosis, I already gave it to you, in fact. And pulmonary tuberculosis, we have already said about it. So what happens is there can be active tuberculosis, otherwise healed tuberculosis. Active will be shown with infiltrates, consolidation, hilar lymphadenopathy, otherwise the healed ones. You will see those nodules, scars, bronchiectasis, or otherwise pleural scarring can also be seen, in fact. And yeah, the you should whenever you're thinking for the pulmonary tuberculosis, always try to see in the apical or the posterior segment of the upper lobe, otherwise the superior segment of the lower lobe. So that is where you should try to always have a look. So this is the emphysema. So how do you diagnose emphysema?
Blackening of lung, hyperlucency,
Good, good, good. And then sub
cavity.
wonderful, wonderful. Subcutaneous emphysema.
Air under the subcutaneous tissues.
Hmm.
What the, forgot the typical
Right.
sign is that
So what
red
happens is, yes, exactly. So what happens, subcutaneous, you all understand, right? So this is the tissue beneath the skin. So, and the emphysema, you all are aware that it refers to the trapped air. So subcutaneous emphysema is when gas or air is there in the layer under the skin. Yeah? If you can notice it over here, both these beautiful x-rays. So, yeah, so emphysema or COPD, you all are already aware. It is mostly referring to the hyperinflation, which is presently common, you know, and yes, the bullae or the avascularity is present, especially in the peripheral third of the lungs, okay, which I already explained why emphysema and the subcutaneous emphysema. So, this is the picture which you see classically, especially in terms of the COPD patients, okay. So, do you all have any questions so far? So, see, mostly we should focus on the cardiological aspects, of course, if when we are getting trained for cardiology. However, we all are physicians first. So, because you can always see those pulmonary vessels as well, those pulmonary pathologies as well. You will be able to notice. So, at least you're not expected to be like a radiologist, trying to identify each and everything, but at least I try to identify the basic things on which you can modify your therapy, you can initiate your therapy, or the emergency conditions at least. If there